So today I want to talk about something that always trips me up, and that's AFib management and complications, risk factors, kind of what do you do when you get an AFib patient, especially as it relates to step 2, step 3. So first off, the way you should approach any tachycardia is first you look at the QRS duration, all right? If you have a wide QRS over 120, then that's more likely a ventricular tachycardia. Whereas if you have a narrow QRS, which is less than 120, then that means the rhythm originates above the ventricle, and it's going to be a supraventricular tachycardia. And within that, you have regular and irregular. Irregular is where AFib falls. And AFib, the way we define that is it's basically an ectopic atrial rhythm. It's when a foci originates near the pulmonary veins, and then that foci causes an abnormal atrial rate, which then causes abnormal beating and kind of messed up functioning, messed up pumping of blood to the rest of the body. So some of the risk factors for developing AFib are older age, if you're over 80, and then if you have hypertension, coronary artery disease, hyperthyroidism, and anything really that makes the heart shape abnormal, like heart failure or valvular dysfunction. In terms of management, so the first thing you want to do is it depends on if their heart rate is, it depends on if they're symptomatic or asymptomatic. So if they're asymptomatic, then you want to keep the heart rate below 110. But if they're symptomatic, you want to keep the heart rate under 85. And the way we do that with rate control drugs is with the beta blockers like metoprolol, atenolol, and if they have hyperthyroidism, then we want to do propranolol. Alternatively, we can use calcium channel blockers. Those are less commonly used, but you can also use verapamil, diltiazem. Digoxin isn't used anymore, but the way it works is it increases parasympathetic tone to the heart, so it slows down the heart rate that way. And then after rate control, let's say for some reason that doesn't work, or the person is unstable, as in they have low blood pressure, then you would do cardioversion. Preferred is electrical cardioversion. But let's say for some reason you can't do that. Then you would do drug cardioversion, and that would be Butylide. And then after that, step number 3 is going to be chronic therapy. And usually that's with beta blockers, rate control. But if that fails, or let's say somebody's under 65 and they're symptomatic, then we would do rhythm control, which is considered a little bit more aggressive. So there's different drugs you can use, and it depends on the person's heart function and structure. So let's say they have no coronary artery disease and a normal heart structure, then you would use flecainide and propafenone. Let's say they have left ventricular heart failure, left ventricular hypertrophy, then we would use amiodarone. If they have heart failure, again, we would use amiodarone. That's just a popular drug to use if somebody has a really complicated condition and they also have AFib and you're trying to manage them. And now, sotalolol, this is unique. You use it when somebody has coronary artery disease. You would use sotalolol, especially if they have coronary artery disease without heart failure. If they have heart failure, again, amiodarone. So another very important piece to all of this is anticoagulation. Now, an important thing to know is before you cardiovert someone, you want to make sure that they were anticoagulated for 3 weeks, or that they developed AFib within 48 hours. Sometimes you don't know either of those two things, or the patient simply doesn't know. So what you would do in that case is a TEE to exclude thrombus. And in general, when managing AFib, you want to take into consideration the anti-cog indications. The way I like to remember this is with CHADS fast females. So C for congestive heart failure, that gets a point. Hypertension gets a point. Age, now think of it this way. You're old, you deserve more respect, that gets 2 points. If your age is over 75, that's 2 points. Diabetes mellitus, that's a point. Stroke, or obviously anything that, you would need anticoagulation for, that gets 2 points. Vascular disease, that's a point. Now, age 65 to 75, that's a point. And remember, CHADS fast females, sex female, that's a point. All right, so if you get over 2, then you anticoagulate. And 1, you do oral anticoagulant or aspirin, or really clinical judgment. It depends. And then if 0, you don't anticoagulate. So oral options are rivaroxaban, apixaban. Those are both factor 10 inhibitors, or dabigatran. That's a direct thrombin inhibitor. And of course, warfarin is another option. So finally, let's talk about complications. So there are 2 major complications of AFib. The first one is tachycardia-induced cardiomyopathy. So what happens over time is you get dilated cardiomyopathy and you get systolic heart failure. Your heart's just not pumping blood sufficiently, and that can be a major issue. Another problem is embolic events, right? The improper beating of the atria can cause a thrombus there, and that can go up to the brain, it can go to the limbs, it can go anywhere. So another reason that this should be probably properly anticoagulated and properly managed. All right, guys, so that was AFib in a nutshell. Thank you.